I'm Dr. Teresa Wagner, an assistant professor in the Department of Lifestyle Health Sciences at the University of North Texas Health Science Center at Fort Worth, and a clinical executive for Safer Care Texas. Today I'm going to be talking about the relationship between COVID-19, health literacy, and health disparities in vulnerable populations. What do these words actually mean? We've been bombarded with complex words that even a person with high education can't understand. Abstract statements like underlying conditions, flatten the curve, and trajectory models. Zarkostis proposes that we've had a global epidemic of hard-to-understand information. It's had devastating consequences to public health, well-being, and economies across the world. So here are the social determinants of health that have an impact on health. Things like our education, our race, our language, where we live, whether we're homeless or have a home, what type of home we have, what the environment is like where we live, all impact our health. So when we look at health disparities in COVID-19, we know that 22% of U.S. counties are disproportionately Black. 52% of our nation's COVID-19 cases have occurred in those communities, and 58% of the COVID-19 deaths have occurred in those communities. The size of the county, nor whether it was urban or rural, has not played a role. And in fact, social conditions such as structural racism and other factors have elevated the risk for COVID-19 diagnoses and deaths in Black communities. I would like to propose that health literacy has also played a role, as it is a social determinant of health. As you can see in the realm of health and healthcare, of the 5 social determinants of health categories, access to healthcare, access to primary care, and health literacy all fall in that category. And we know that these communities also tend to have low access to healthcare and low access to primary care. In an op-ed in the Atlanta Medical Association Journal, Iris Feinberg states that there's a huge gap between how health messages are communicated in COVID-19 and what health consumers can understand to make good health decisions. Health literacy in COVID-19 has been identified as a silent killer that vital signs and oxygen saturation measures do not help. In fact, over 66 million people cannot read or understand most of the health materials about COVID-19. When we talk about health literacy in COVID-19, we know that the average American person reads at the 8th grade level, and 20% read at the 5th grade level or below. 40% of elderly adults read at the 5th grade level or below, and 50% of African Americans and Hispanics read at the 5th grade level or below. So think about these communities where if you're an elderly African American, what your chances of being able to understand the information is. We can do better. Providing COVID-19 information that all Americans can understand regardless of their social determinants and literacy level, and understand how to stop the spread of the disease. So when we look at how these messages have been broadcast, we know that 33 million U.S. adults do not have internet access. That means they're not out there Googling information on the internet. In fact, they use radio and TV 5 times more than print, and most of the information that's been available has been on print on the internet. They rely more so on family and friends, and what if those family and friends don't have the right information? And so we need to be developing TV and radio PSAs that are concise and understandable in plain language for people to understand. Carefully written documents are important, but having them available on the internet is useless for adults with low health literacy. We need to have plans in place. Help people get health information when it's needed most. And even before I read Feinberg's op-ed, I was thinking to myself that in Texas, our community health workers need to be out there on the front lines delivering this information to these disparate and underserved populations. We need to have community-wide partnerships and collaborations with people that they trust to deliver the information in a way that they can understand. Before emergencies strike, we need to be prepared. From trusted sources of accurate information, community organizations, adult education programs, healthcare providers, and get to these hard to reach populations. In Texas, as I stated, community health workers can serve as a big part of that plan. There's over 4,000 community health workers in the state of Texas, and they need to be out there on the front lines. They're already a part of the healthcare team, and they're from the communities that they serve. They know the culture, or they're a part of the culture, and they're well networked and trusted. So I did an informal survey of community health workers about COVID-19 information. And what I found was that most of the community health workers were either not at all prepared, only slightly prepared, or moderately prepared. None of them that answered the survey were very or extremely prepared to dispense COVID-19 information. How they got the messages out was also important, because a lot of them used social media, but we know that only 81% of the US population have a smartphone, and that's decreased as your income decreases. So 71% if you make under $30,000 have a cell phone, and 66% if they lack a high school education. So that shows you that a lot of these messages were not reaching these disparate populations. So the other ways that they reached them were with phone calls, because they couldn't go visit in person, and word of mouth. So it's important that that word of mouth also be accurate information. So topics that people need, according to community health workers, in order to reopen, interestingly, just knowing basic facts about COVID-19. We're still there. We're halfway through this epidemic, and we're still where people don't even understand basic facts. Also, the second highest was understanding the safety precautions. We've been expecting people to follow those for almost 4 months now, and yet not everyone in these populations that community health workers serve even understand that basic information: hand washing and social distancing. So where do communities find information for COVID-19? Interestingly, friends or family and the internet. This verifies what Feinberg had said in terms of TV and radio are still very dependent, even though internet is used by those who have access. But friends or family, that's an important note, because if friends and family are giving inaccurate information, then those communities continue down that path of inaccurate information. What made it hard for community health workers to get the information they needed to get to their communities? Well, some of the things that they mentioned was there was too much information and that it was contradictory, that inaccurate information was given in the beginning, that they had the feeling that their community was in peril because there wasn't a way to get tested, and just not knowing at first what it was and how it affected people. And lastly, there was nothing in place for us to prepare for something such as this. So what I'd like to propose as a solution for the future is that we need to have an emergency management health literacy model. We need to have prepared communicators, such as community health workers, who are armed with clear communication and that can be deployed in public health emergencies such as COVID-19. That way, all Americans, regardless of social determinants and health literacy and literacy levels, can understand how to stop the spread of a communicable disease, which would then reduce disparate and preventable harm. Here's my contact information. Thank you for attending today.